Thank you, Sarah. It's a pleasure to be here and have the opportunity to present our recently published paper on IV ketamine treatment response. Okay, so at this point, we know that ketamine works remarkably well for some people, but it also doesn't work for many people. And who benefits versus doesn't benefit from ketamine isn't very well understood. So members of our research lab have been particularly interested in what treatment response to ketamine in the real world looks like, and also for whom ketamine seems to work especially well. To investigate these questions, we collaborated with a private IV ketamine clinic in Houston and analyzed data from 328 depressed adult patients who received an acute course of treatment. As part of the clinic protocol and prior to their first infusion, patients completed the quick inventory of depressive symptomatology self-report, or the QIDS-SR, to assess depression symptoms and severity. They also completed the Childhood Trauma Questionnaire, or the CTQ, to assess for history of childhood trauma. And for those of you who are not familiar with this scale, the CTQ is a 28-item self-report measure that assesses 5 domains of childhood trauma. These domains are sexual abuse, physical neglect, emotional abuse, and emotional neglect. Patients then completed the QIDS-SR at their next clinic visit and prior to their next infusion to measure their response to the previous infusion. We analyzed these patients' QIDS scores over 4 clinic visits, so measuring their responses to a total of 3 infusions. Just a few highlights on the study sample I wanted to mention. So the mean QIDS-SR score for our sample, across the whole sample, was 17, which reflects a severe level of depression prior to treatment. The sample was split pretty evenly in terms of gender. Patients were taking a variety of medications during treatment. About 80% of the patients reported a primary diagnosis of MDD, and over half of the patients reported a comorbid anxiety disorder. So this really, truly was a real-world sample. So for the analysis, we conducted growth mixture modeling to identify distinct response trajectories of these patients over the 3 infusions. So growth mixture modeling is a really neat approach to data analysis because unlike many other approaches, it's a hypothesis-free, data-driven approach. So we really had no idea going into the analysis how many unique treatment response trajectories there would be, or said another way, how many distinct patterns of response would emerge from the sample of patients. So as illustrated here, the GMM analysis yielded 3 distinct response trajectories. The first and largest group of patients, about 40% of the sample and represented with the black line on the figure, was severely depressed at baseline and then showed a rapid and robust response to 3 infusions. A second group of patients, shown by the red line, about 30% of the sample, were severely depressed at baseline and had a minimal response after 3 infusions. This is the group you definitely do not want to be in if you are seeking ketamine treatment. The third group of patients, the remaining 30% of the sample, and shown by the blue line, were only moderately depressed at baseline and had some improvement, but definitely not a very robust response. So this type of response trajectory analysis isn't new in depression research. In fact, it's been done for a number of treatment types for NBD patients. Here you can see figures from studies looking at response trajectories to antidepressants, TDCS, RTMS. There have also been trajectory studies on different response patterns to patients engaged in psychotherapy. But to our knowledge, our analysis was the first attempt to characterize treatment response trajectories for ketamine. So this brings us to the second step in our study. So our first step, again, was to identify the different patterns of response to ketamine. And similar to other treatments for depression, patients didn't all share the same antidepressant response to ketamine. Some patients just didn't respond well at all. So the second step, and what we believed was an especially important question to ask, was whether there were identifiable patient factors that could predict membership into these groups. So again, using the GMM approach, we investigated what demographic and clinical factors, if any, associated with these groups. And this here is what's called a word cloud, and it represents all the patient variables that were collected and analyzed in the GMM. I want to let you know that one of my co-authors, far more hip and graphic savvy, suggested this word cloud image, and I think it's pretty neat. Anyway, in this study, factors including age, BMI, or unipolar versus bipolar depression did not significantly associate with membership to a particular group. However, we did find some overall differences in terms of gender, dose, concomitant opioid use, and comorbid attention deficit disorder. And a very interesting and relevant finding related to, a history of physical abuse, because this factor was actually the only one that differed between the two groups that were severely depressed at baseline. So patients who reported childhood physical abuse and were severely depressed at baseline were more likely to experience a rapid and robust treatment response than those patients who did not report a history of physical abuse. And also of interest, though it didn't reach a level of significance, patients in the severely depressed, rapid, robust response group showed the highest proportion of clinically significant maltreatment in all of the domains measured except for physical neglect. So it appears that patients who report a significant childhood physical abuse history may especially benefit from IV ketamine treatment. Further, since we know patients with trauma histories have a lower likelihood of response to first-line treatment, ketamine, therefore, may be an especially good treatment choice for severely depressed patients who report childhood trauma. So in terms of where we go from here, and I do hope that attendees will have some thoughts and suggestions to add to this, we hope to replicate these studies and replicate these findings with larger samples, with clinic samples, with other clinic samples. And, while we collected a lot of information about these patients and had quite a rich data set to work with, it wasn't exhaustive. And in the future, we would love to collect additional historical data from patients, including things like patient suicide history, and also more recent trauma history. Also, as a therapist myself, working with patients with TRD, I'm very interested to see how and whether concurrent psychotherapy during ketamine treatment may affect response to treatment. So that actually brings me to the end of what I prepared for today. And I just wanted to share a slide expressing my thanks and gratitude to everyone who contributed to this project. And I'll turn it back over to Sarah or Rupert.
That's great. Thank you very much indeed, Brittany. That's really interesting. Lots of interesting things to sort of unpack there and perhaps mull over in a bit more detail. We've just recently hosted a conference called Ketamine 2021, where a variety of speakers spoke, and Carla Canuso spoke about S-ketamine and the long-term data there from their phase 3 studies. And what she said was that, in fact, from their data, it looks as if the severe patients in that cohort did better than those who were less severe. And in fact, those who were more treatment resistant also did better than those who were less treatment resistant. So it's interesting to see that that holds up in the real world as well.
Mm-hmm. It is. It's fascinating, and I think important to recognize that the patients that seem to do especially well with ketamine are those that are the hardest to treat. And it's just, it's both wonderful that seems to be happening, but also perplexing a bit, but may actually help us better understand kind of the mechanisms of action, why ketamine may be working so especially well for this very severely depressed, very treatment resistant population. I'm curious, in that call, were there any sort of hypothesis sort of brought up as to why they thought that might be the case?
I was going to invite you to speculate on what might underpin that relationship with the severe physical,
Sure.
and the physical trauma group as well.
Of course. So I actually have another slide that I didn't plan to present, but I have one that sort of actually speaks to that question. So hold on, let me just pull it back up here. Okay, can you all see that?
Yep.
Yeah.
Okay, so we mentioned this in the paper. We have this hypothesis related to behavioral sensitization and why ketamine might work so well for these folks. So trauma, particularly trauma that involves like severe, uncontrollable or inescapable stress, may induce like the sensitization of symptoms. And hopefully everyone on the call sort of understands what the process of sensitization is. But in other words, we think, of a history of trauma as lowering a person's stress threshold and then increasing their reactivity to subsequent stressors, including a likelihood of mood episodes. And we know that from preclinical models, at least, NMDA receptor antagonists block the induction and expression of behavioral sensitization to stress. So resistance to conventional antidepressants in this specific population, this traumatized population, may be more related to the expression of sensitization by early stressful events. And this expression could be blocked by ketamine. So to put in metaphorical terms, if we kind of imagine early childhood trauma to be like a severe and painful wound, and then the pain emanating from that wound being depression, this wound, because it's so deep, it might scab over, but it doesn't actually ever heal. And so that wound is still more vulnerable to opening up to subsequent bumps and scrapes of stress. And for every bump and scrape that hits the wound is then re-injured, it opens up again, and then we have another depressive episode or a worsening of one. So ketamine may act as like some sort of remarkable cast or bandage that actually protects this underlying wound and vulnerability. So therefore, it just sort of kind of prevents some of that pain or depression that might have otherwise resulted from additional and future stressors. So that's sort of kind of the idea that we're playing with, just that it might be, very protective for these folks moving forward. They, these are folks who unfortunately have a terrible sort of course or illness course, right? Have all of these subsequent mood episodes. And if you can kind of catch them and get them some ketamine, it might actually help prevent them from having subsequent episodes or a worsening of the episode.
But what you've shown is that the ketamine actually improves the current pain.
Mm-hmm.
So that's, if you've got that, I mean, I like that sort of analogy. It's the sort of thing that I thought, oh, I'll steal that and use that in clinic. I quite like that. But I'm not. Does it actually hold? Is it actually supported by your data? Because if you were using ketamine directly after the wound, then you could see that might be useful to block the subsequent sensitization. But what you seem to be saying is that it's the vulnerability to pain, mm-hmm. or the vulnerability to new stress that ketamine might be useful for, whereas in fact your data is showing an effect on the current pain.
Mm-hmm. Totally fair. And yes, it's not a perfect metaphor, but I do think, if we are going to continue using the metaphor, if you are walking around with a gaping wound, and it is painful, even just putting some sort of bandage across the wound might instill some sort of hope that you're not going to continue to bump up against something, or something might fall upon the injury to make it sort of dreadfully painful. I think that just as a therapist who works with patients who are depressed, one of the things that you see with people who are depressed is just this horrible, dark, hopeless perspective on life. And certainly, at least anecdotally, we hear from people who have undergone ketamine treatment that there's just this sort of like cognitive shift that happens when they are, sort of receiving ketamine, where they just realize that they can kind of see the world differently. They can see themselves differently. They can see their future differently. And that perspective is something that's really it's really hard to hold on to when you're depressed, even if, logically you can kind of reason with yourself that might be the case. But something effectively happens with sort of ketamine treatment where you actually feel that to be true. And then that can kind of help you sort of continue to be protective in some way as sort of additional bad things might happen or stressful things come your way.
So you're sort of bigging up the hope aspect of it rather than the analgesia aspect of it. I understand that. Yeah, good.
Yeah, I think so. I mean,
Yeah, I was just going to encourage people. I don't want to hog all the questions, although actually I really do, but I have to hold back because there's a lot to talk about here. So can I encourage people to use the Q&A rather than the chat? But we will take the questions that have gone into the chat, but we're going to prioritize those that have come from the Q&A. But just before we do that, I'm going to just make perhaps one further sort of hypothesis that we can perhaps come back to later, which is that it's to do with the retraction of dendritic spines that is seen in depression and in emotionally sort of in impoverished backgrounds, if I can put it like that. So you've got a stressed dendrite, and the ketamine allows it to
just magically regrow.
Magically regrow, yeah. The dendritic spines regrow. Yeah. Anyway, we'll come back to that aspect. So anyway, look, we've got a question here from Kern, and I'm going to read. It's a long one, so I'm going to just read it out. This is now your second study showing better results in subjects with childhood adversities. So we're keen to hear about the first one. Could it be that dissociation is a psychological mechanism, is an intermediate mechanism in this so-called antidepressant effect? Because with most other treatment modalities, childhood adversities are a negative predictor of outcome. And he says, thanks so much for these fascinating findings.
Sure. Okay. So it's a wonderful question. Thank you for bringing that up and asking. I think a lot of people are curious about that, and whether or not dissociation is really sort of this key piece. I'm aware of previous findings where dissociation really didn't associate with sort of treatment responsiveness or sort of antidepressant effect. But I'm aware of some other data that does support that. So I think it's too soon to say definitively whether or not dissociation is that sort of intermediate mechanism, but it could be. I mean, I think that another thing that's really I find to be curious and interesting, and something that we're actually hoping to investigate a little bit further by surveying some clinicians out in the real world about sort of how they determine dose. In our sample, and I don't know if Dr. Wells is on the call and she wants to sort of chime in here, but dose was really determined on a case-by-case basis. So the 0.5 megs per kg calculation that's in most of the RCTs was definitely used to sort of start dose, but then it was kind of titrated and adjusted until these patients were reporting kind of like a mild dissociative effect. Because I think clinically in her practice, Dr. Wells has felt like that's a really important, aspect of the treatment. And that, it's not always 0.5 megs per kg. Sometimes it's a little bit more, sometimes a little bit less. So I do think it's an important thing that we need to sort of more carefully study and better understand if it's sort of related to sort of these treatment outcomes.
So we've got a question here which leads on from that. Could you say a bit more about how the other predictors were related to antidepressant trajectories? So obviously you've got physical abuse has come out in this model, but I see that child sexual abuse didn't come out. Child emotional abuse didn't come out as a predictor. So do you want to say something about the ones that didn't come out as well? Is that?
Sure. So I guess I could sort of jump back to the first study that we did. So in our first study, it was a smaller sample, it was only 63 adults, and it was a hypothesis-driven study. And actually our hypothesis was that patients who were reporting sort of a history of childhood trauma would actually not do as well as those that didn't, right? Because that's just sort of what we expected given all the other treatments for depression. But we found the opposite. It was really kind of cool. And we found that a history of sexual abuse, physical abuse, and also cumulative maltreatment loads. So basically, the number of domains that met for clinically significant trauma sort of predicted a sort of higher rate of remission for these folks. And also it kind of in general didn't quite meet significance for response, but it really was this like fascinating finding where it was like the more trauma you reported, the kind of better off you were to respond to ketamine.
So that wasn't replicated in this study, is that right?
So we didn't find, so I mentioned before, it didn't reach significance, but out of all of the, the thing that was replicated was the physical abuse finding. We did not replicate the sexual abuse finding. And we did not replicate the cumulative maltreatment load finding. And so this is why, we want to keep investigating and do more studies with more samples to better understand this.
How was the first sample different from this one?
The sample was just smaller. It was actually, we collaborated with the same clinic, and it was only 63 patients, but pretty, actually in terms of sort of matching up the sample in terms of the diagnoses, gender, the types of medications these patients were taking, it was a very similar sample.
And was it a subsample of this current sample, or was it a different sample?
Yes, it actually was. So the 63 patients that were included in the first sample were also included in this current analysis.
Okay, thank you. Okay, so Sagar from Michigan says there are many problems with inter-rater reliability of MDD, and I noticed that you used a self-report, the QIDS. Mm-hmm. Do we have any way to clarify the MDD diagnoses here? For instance, do the demographic and other features of patients with MDD from this clinic resemble usual TRD patients in research studies from academic centres? So to what extent are these patients like the TRD patients from academic centres?
It's a great question. So I think it's unlikely that these patients are very, very similar to the folks that are enrolled in these TRD research studies, though I do think that they probably are quite similar to those who are seeking treatment at academic medical centers that are, just like community clinics, just based in academic medical centers. I think obviously one of the limitations of this study is that, the diagnoses that we have on these patients were all self-report. They didn't undergo sort of a careful, extensive psychiatric interview. They didn't do a mini, and that's something that we're actually really hopeful to have a better handle on in our studies moving forward, as a way to sort of, really figure out, is MDD the primary diagnosis? Is it not? In these sort of RCTs, you just have really clean, but not very common patients participating. And, I think that's why it's really important to do real world outcomes research, because, these are the patients that get excluded from these trials, but are still very, very sick and really need treatment. And so they, pay a lot of money out of pocket to go get, ketamine treatment, and may or may not respond well to it.
Dr. Wells, we've promoted you to a panelist, so we can hear what you can say.
Great.
If you
Okay.
want to comment on this, you can put your video on as well if you want. You really genuinely are in clinic. Yeah, great.
So I don't have much beyond what Brittany actually was speaking to add to that. I think everything she said was exactly my feelings on it.
Okay, great. Well, maybe we can come back to you for some more insights a little bit later, but let's just get through the questions now. So did the data separate in regards to total dose used in the trauma population? So dose you had was obviously one of the factors that was relevant to response.
Yeah. Yes. Okay. So I can speak about that. So the dose did come out as significant, but it's significant in a really important way. So it was significantly lower for the moderately depressed gradual improvement group than it was for the higher depression group. So the sicker patients were receiving on average a slightly higher dose, but significantly so than those in the moderately depressed, the patients that were starting out at a more moderate depression level. What didn't differ, and what I think is really important to point out here, is that the doses didn't differ between those two severe depression baseline groups. So there are some, hypotheses out there that if you just dose higher, then you will, sort of be more effective. And that's not what we saw. The patients who improved in the rapid and robust response group, their doses weren't any higher than those patients who were in the sort of severely depressed but sort of minimal improvement group. So higher dose doesn't mean sort of more effective treatment, at least in this study, which I think is a really important finding to, obviously replicate, but was interesting to see for sure.
I'm going to ask a related question, then we'll come on to Raquel's question in just a moment. One of the predictors that you did find was concomitant opiates. Mm-hmm. And I've sort of been interested in this, I wasn't quite sure which way round the association was, because of course, if you've given naloxone to people, it's suggested that might reduce the antidepressant benefit. So, if you were being just incredibly simplistic about it, you might say, well, why not give some opiate and it might improve the benefit. Which way round was the association in your cohort? Was it people who were on opiates who did less well, or was it people who were on opiates did better?
People on opioids did better.
They did better.
And the sort of our thinking to explain that is that patients who are really sick are likely to be taking more medications, heavier duty medications. These people are sicker and yet they still do better. So it's pretty.
Was that not factored out in the analysis? Were these not independent effects? Presumably it was an independent factor, the opiates, independent of severity. Or was it catered for in the statistical analysis, or does the analysis not do that?
I don't think the analysis does that. I mean, we didn't control for it, but what we did find was just patients. So essentially, just to be really clear, patients who, patients who listed out, here, I can share my screen again. We can just take a look.
Yep, do that.
Sure, hold on. Let me see. How do I share my screen?
It's currently sharing.
Oh, you're right. Sorry, let me take that off. Sorry. I went ahead and did some highlighting before we started, just in case these questions came up. So here's the table where we can really sort of look at all the different factors. And there was a significant difference between the severely depressed minimal improvement group and the moderately depressed gradual improvement group. So basically the two folks, the two groups that you don't want to, well, not that you don't want to be in, but not the rapid and robust group. And the folks in the severely depressed minimal improvement group had a higher percentage, a higher number of patients were listed opioid medications than those in the moderately depressed gradual improvement group. So it's not, I'm sorry, I misspoke. So it's not that having taken opioid medication predicted that you would do better on it. It was just that this more severely depressed patients who had minimal improvement, more of them were taking opioids than those in the moderately depressed group, which makes sense. Sorry.
Thanks very much. Raquel asked the question, I've received a huge number of unsolicited complaints from people who seem to be triggered into traumatic memories during their ketamine infusions. This has made me concerned about using ketamine infusion to treat PTSD. How do we balance the potential for benefit and harm in ketamine treatment for patients with PTSD?
So I think, Brittany, I can speak to that a little bit. So when we have a patient with PTSD come in for treatment, we like to make sure that they are in concomitant therapy and have a psychiatrist to address any traumas that come up during treatment. But starting with the 0.5 milligram per kilo dose and, only titrating up to a comfortable level, we generally try to avoid pushing them over the edge into feeling like they are not able to control the thoughts or hallucinations that they're having, which I think can really force them into a feeling of being unable to control their environment again, and reinforcing some of the PTSD. Whereas if you keep it slightly below that level, a lot of people try to push it to 0.75, 1 milligram per kilo, because of data showing that a higher dose really is more effective. But for some patients with PTSD, 0.5 milligram per kilo, 0.4 milligrams per kilo, that's all they need, and they still get the 70 to 80% effectiveness.
Okay, thank you very much. The next question is, could you speculate why physical abuse compared to other forms of abuse was a more sensitive indicator? Ketamine response, data of response, as opposed to the type of trauma.
Yes, I can speculate, but that's all I can do.
Well, we invite you to do that. That's fine.
Right. I mean, I think we were, so I'm just trying to think in what order I want to say this. With this behavioral sensitization hypothesis, right? Uncontrollable, inescapable stressor. I mean, that is childhood physical abuse, when you just don't even know the next time you're going to be, hit or beaten, or, I really think that it's, I think that versus something more like that, more so than something like emotional neglect, might just be a more sensitizing type of trauma. I mean, that's my speculation purely. I think that's also perhaps why sexual abuse came through in that first study as well. Unfortunately, it didn't come out in the second one, but I think that maybe a reason why physical abuse versus other forms of abuse might be more sensitive indicators.
And I think the answer to the question about whether you looked at PTSD as an indicator rather than the burden of abuse score, was that the diagnoses weren't concomitant diagnoses weren't a factor here. Is that right?
That's correct.
You can see that in the table, can't we?
Right. Yes.
Yes. PTSD didn't come out.
Right.
Yeah. Okay. Good. And then the final question before we move over and bring everybody onto the panel: have you measured any of the subjective experiences of patients relating to ketamine infusions, for example, mystical, spiritual, and dissociative experiences?
That Dr. Wells would need to answer. We did not formally measure it.
No, we subjectively ask them if they're having experiences, and again, we sort of titrate to the lower level of an experience like that, but we don't use any of the formal measurement tools. We had talked with someone actually in Dr. O'Brien's group about using a formal measurement tool during the infusions, but the patients were really resistant to answering questions during the infusion. They seemed to feel like that sort of broke the magic of the infusion, and was really bothersome during the infusion. And right afterward, a lot of them also did not want to sit and answer questions. They kind of wanted to go eat, since we make them fast.